someone who may have just had the concept of donor eggs mentioned to them as an option for them to build their family, what might they expect from a typical donor egg protocol, IVF cycle, both for them as a recipient, but also on the other side, what's going on with the donor too?
Yes, that is a very interesting question, because I suppose we all think how difficult it will be, how time-consuming and physically demanding will be. Once that the donors has been selected and the recipient has been matched, then at that stage, the medical aspect requires two main important points. One is to synchronize, so make the recipient uterus preparing at the same time while the donor also start producing eggs. These are normally dealt with by two different teams, two separate teams. There's a team looking after the recipient, which will aim at developing the endometrium in the best way as possible. We normally use medication as simple as tablets, and the tablets are made by the same hormones, which sometimes are in the contraceptive pill or in the hormone replacement tablet. This is estrogen, which is taken daily and aim at thickening and develop the endometrium, which is then followed by ultrasound normally. So if women undergoing to the pathway of accepting an egg, so a recipient will have normally an ultrasound at the very beginning to assess that there is no issue with the uterus, and at the same time, on the other hand, there will be the recipient also, the donor also going through the same assessment. And then they both start the treatment more or less at the same time. There will be only a few days of discrepancies, and the assessment normally is done by ultrasound and perhaps by blood tests. So a recipient normally has 2, maybe 3 ultrasound during this process, which can be done at the beginning after 7 to 10 days, and then perhaps after 3 to 4 days to make sure that the endometrium stays stable. At the same time, the donor is instead taking drugs which are slightly more invasive. You know, they're the injection. They're still hormones, but they are aimed at stimulating the growth of the follicle. You know, every woman has follicles inside the ovary, and the follicle need to grow under the effect of the hormones. So the donor normally is followed in a bit more close way, because there is potentially the risk that the donor may produce too many follicles, too few follicles, because, you know, what would be the winning game is to get the appropriate number of eggs, which of the appropriate maturity, so they can be matched with the sperm and produce a competent embryo. So the process of donor lasts approximately 2 weeks. The process of treatment of a donor lasts approximately 2 weeks, and this is the time when the follicle will be growing during the daily injection. So we are talking about at the moment to a synchronous treatment. So a treatment where the recipient will accept the fresh eggs from a patient. And then we discuss in a moment why fresh and frozen may be different. So approximately after 2 weeks of daily injection, the donor will have developed follicle of size and maturity which we assume they will contain a competent eggs. At that time, the donor will be invited for an egg collection. So we'll take a final, what we call trigger injection, which has the purpose of making the eggs with the exact amount of genetic material so they can be matched with the sperm, because the eggs normally has the double amount of genetic material compared to the sperm. So the trigger injection will make the eggs throwing away half of the genetic material so it can be matched with the sperm and create again an embryo with the appropriate amount of genetic material. So this injection normally is given 36 hours before the eggs is extracted, and is extracted through a small surgical procedure when the donor is asleep with an intravenous sedation, with medication given through the vein, but not with a general anesthetic. So the procedure is perfectly comfortable, and the donor is not aware of pain during this procedure. And the eggs are extracted, handed to the laboratory where they are cleaned and they are exposed to the sperm. Very often in a donor cycle, the sperm are injected directly inside the eggs. However, in many other situations, sometimes if the sperm are perfectly normal, we can actually allow a natural selection. So we normally select 30,000 with sperm, and we put together 30,000 sperm with one egg, and we let them to do the work by themselves. So on the other hand, on the other side, the recipient during this time, she has been preparing the line of the womb with tablets, and the tablets would have made the endometrium to be of a certain thickness. We normally like to be between 7 and 11. Anything less will trigger some anxiety in the doctor. Anything more as well will trigger some anxiety. Not because there is a problem, just because as a doctors or as a specialist, we like always we don't like outliers or we feel uncomfortable to work with outliers, but not because it doesn't work. So when the eggs are extracted, they will be matched with a sperm, and the recipient will be informed with their partner, or if she's using donor sperm, will be informed of how many eggs have been collected, and then how many of those eggs will be exposed to sperm. It is interesting that sometimes people feel that as the many eggs they may obtain, the better is. But actually, when you look at the studies, there is a magic number, which is 8. Okay, so the magic number indicate that, it's been a safe stimulation, hasn't put at risk to the donor, and actually has created a good maturity of the eggs. So getting too many eggs is not necessarily the best option, and of course getting the few, is not a good option as well. So at that time, the recipient will be informed that the eggs are there, that's been matched with the sperm, and the next day, the recipient will receive a call, and she will be told how many of the eggs are fertilized. The reason why we do the next day, because normally you look at the eggs 16 hours after they've been exposed to the sperm, because this is the time when the egg start to showing sign of fertilization. So from that point onward, the recipient will then expect a phone call from the laboratory that she will be informed what's going on with her embryos. So let's say that from 8 eggs, an average fertilization will be 70%. So maybe 5 to 6 would have fertilized. And those eggs will start growing. We cannot expect all of them to become beautiful babies. The genetic is important. We know that as a woman age increases, the genetic of the eggs also deteriorate. That's the reason why, unfortunately, miscarriages are more common when you grow older, and abnormal genetic pattern of the babies can be also more important as a woman age increases. So we are expecting to sort of be a selection. As the day goes along, we are expecting to see less and less good quality embryos. Mm-hmm. And the further we can wait for an embryo is day 5. After 5 days, an embryo wants to start implanting somewhere. So there is a mechanism called hatching, where the embryos start coming out of the shell and want to find a place where to host. So that's the reason why we aim at waiting 5 days, but not because waiting 5 days makes the embryos better. It's just giving us the possibility to spot which one are the best embryo. Mm-hmm. And through a donor cycle, because we're using eggs of a young donor, we would expect the eggs to be genetically quite good. So we would expect always to have one or more than one embryo at the top quality, where one can be used fresh and the other one can be used or can be stored. Mm-hmm. During this time, the recipient uses another hormones. Well, on the day of collection, we introduce another hormone, which is called progesterone. The progesterone has 2 effects in a woman's uterus. One is to prepare the uterus for the implantation, and also is to prepare the uterus for the bleed. That's the reason why, the progesterone will be important at the beginning, before we put the embryos back, and then will be important immediately after to make sure that we support the embryo, because the embryo at the very early stage start communicating with the body of the woman and start telling the woman, please, can you produce progesterone? But in a recipient, because she hasn't ovulated herself, she will not be able to answer the messages. So we give progesterone from outside. Yeah. And we give progesterone until the pregnancy test is due, which is normally 14 days after the collection of the donor, or at the same time the donor had their collection. She will be monitored, she will be followed, she will be advised that she may experience some bleeding, very light bleeding, like the hand tail of a period. She may experience some cramp pain, but it is extremely rare that she will suffer any medical consequences. We normally advise the donor not to try to conceive or to use contraception because she may be very fertile in the few days immediately after their collection, because you may expect some eggs to carry on maturing and being ovulated. So we normally, the donor can monitor medically. They normally go back to work the next day, but they will continue to be monitored by the team, so to make sure that they are physically and emotionally well, because it's also an emotional burden for them. They're giving an amazing gift, and I think they need to be followed from this point of view. So this is the journey, and this is the journey which happens when you're using fresh eggs. If you're using frozen eggs instead, the process of freezing the eggs has already occurred before, because the donor's gone through the process of ovarian stimulation, daily injection for 2 weeks, collection and freezing of the eggs. The reason why the frozen eggs process has taken place and has become now very widely accepted is because it's simpler, it's faster, and you do not require to synchronize the life of the donor with the life of the recipient. So you don't need to synchronize their social life, their personal life, their working life, and the biological aspect of their life. So it's much simpler, and it's made it somehow slightly cheaper as well. However, the pitfalls of those are several. One is that there is still a biological disadvantage in freezing and thawing the eggs. So there is a very important skill that the laboratory need to acquire. So not all the laboratories have the same results. And this is clearly, there is a human factor, very important, which is down to training and to the numbers, like every profession. The more you do, the more you become experienced in something. There is also the effect of the freezing and thawing itself. Even with the new technology, we believe that 90% of the eggs may survive in the freezing and thawing, but still can actually cause a small detriment in the quality of the eggs. Mm-hmm. There's been very recently a study, and I'm going to speak very briefly about this, where it shows that using fresh eggs can give an advantage in terms of how many babies can be born at the end when you compare to the frozen eggs, but also gives an advantage in terms of health of the baby. There's been a very small differences, but between 25 to 22%. So if you use fresh eggs, the perinatal outcome, so the outcome of the baby at birth, is a bit better compared if the baby was conceived through the frozen eggs. And this, I think, is very important. It was a very interesting study looking at 37,000 women going through the two different pathways. The downside of the fresh eggs is that you get more twins. You got 37% increase in the chance of having a multiple pregnancy, even when you compare for the same number of embryos which have been transferred between the fresh and frozen eggs, and you adjust for all the possible variable, women age and characteristic of the women. So in clinical terms, it's better to use fresh eggs. There is a very marginal advantage in the chance of having an healthy pregnancy and a healthy child at the end. The advantage is very small, but on the other hand, the possibility to use fresh eggs is much less, because there are not so many donors at the moment available for how many recipients would like to have a fresh eggs. And I think how we understand a bit more what is the mechanism that create these differences, I believe that eventually using fresh and frozen eggs will be very equivalent at the end. How we improve the handling of the biological material in the lab, the training, I think will make this difference very soon to disappear.
Yeah, that's really, really useful. Thank you. And it's fascinating just to hear you talk about it. And I have so many people come to me going, I don't know whether to go fresh or frozen, and what do you think? And I'm like, well, I'm no expert. I don't know. So yeah, just listening to you talk about that, there are a lot of variables and things to consider when you're going down this route. And it's not just the kind of the outcomes of the studies, it's kind of what works for you, and kind of the cost implications and the convenience and on all of those different things as well. And what I really liked as well was when you talked about the optimum number of eggs, because I would have never have guessed it was 8. When we went through our cycle, we got 8 eggs. And I remember thinking, oh,
Yeah.
I was expecting more, having really struggled to get eggs myself, but we had 5 really great quality blastocysts from that. And so I think it's really useful for people to understand that it's not just about getting a huge number, it's that quality that's really, really important. And also really good to know that you're kind of thinking as well about the donor, because as a person who's used a donor, I would hate to think that someone has been overstimulated just to get the most number of eggs from that person, at the risk of their health as well. So I think that's really important. It was really nice to hear about what they go through as well, because although we don't know each other, we're in separate places and go through separate experiences, it's very much linked. And yeah, there's a connection there, I think.